Aspirin. Once upon a time, everybody over 50 was supposed to take a baby aspirin. Now we make it a point to tell people to stop. What is going on? I'm Christopher Labos, and this is On Second Thought. Our recommendations vis-a-vis aspirin have evolved at a dizzying pace. The youngins watching us right now don't know what things were like in the 1980s. The Reagan era was a wild, heady time where nuclear war was imminent and we didn't prescribe aspirin to patients. That only started in 1988, which was a banner year in human history. Not because a number of doves were incinerated by the lighting of the Olympic torch at the Seoul Olympics. Look it up if you don't know what I'm talking about. But because 1988 saw the publication of the ISIS-2 trial, which first showed a mortality benefit to prescribing aspirin post-MI. Giving patients aspirin during or after a heart attack is not controversial. It's one of the few things in this business that isn't. But that's secondary prevention, treating somebody after they develop a disease. Primary prevention, treating them before they have their incident event, is a very different ballgame. And here, things are messy. For one thing, the doses used have been very inconsistent. Now, we should point out that the reason for 81 milligrams of aspirin is very arbitrary and rooted in the old apothecary system of weights and measurements. A standard dose of aspirin was 5 grains, where 20 grains made 1 scruple, 3 scruples made 1 dram, 8 drams made 1 ounce, and 12 ounces made 1 pound because screw you metric system. So 5 grains was 325 milligrams of aspirin, and 1/4 of the standard dose became 81 milligrams if you round it out to decimal. But people have actually tried all kinds of dosing structures with aspirin prophylaxis. The Physician's Health Study used a full-dose aspirin, 325 milligrams, every 2 days, while the Hypertension Optimal Treatment, HOT trial, tested 75 milligrams daily, and the Women's Health Study tested 100 milligrams, but every other day. Ironically, almost no one has studied 81 milligrams every day, which, is weird if you think about it. But the bigger problem here is not the variability of doses used, but the discrepancy when you look at older versus newer studies. Older studies, like the Physician's Health Study, did show a benefit, at least in the subgroup of patients over 50, which is probably where the everybody over 50 should be taking an aspirin comes from, at least as near as I can tell. But more recent studies, like the Women's Health Study, Aspirin, or Aspire, didn't show a benefit. Now, I know what you're thinking. Newer stuff is always better. That's why you should never trust anybody over 40. But the context of primary prevention studies has changed. In the 80s and 90s, people smoked more, and we didn't have the same medications that we have today. We talked about all this in the beta blocker video to explain why beta blockers don't seem to have a benefit post-MI. And we have a similar issue here. The magnitude of the benefit with aspirin primary prevention has decreased because we're all just healthier overall. So yay, progress! But here's where the numbers matter. No one is saying that aspirin doesn't help. It does. If we look at the 2019 meta-analysis published in JAMA, there is a cardiovascular benefit. The numbers bear that out. And I know you're all here for the math, so here we go. Aspirin reduced the composite cardiovascular endpoint from 65.2 to 60.2 events per 10,000 patient years. Or, to put it more meaningfully in absolute risk reduction terms, because that's my jam, an absolute risk reduction of 0.41%, which means a number needed to treat of 241. Which is okay-ish, not super great, but maybe justifiable for something that costs next to nothing. But the trade-off is bleeding. Major bleeding increased from 16.4 to 23.1 bleeds per 10,000 patient years, or an absolute risk increase of 0.47%, which is a number needed to harm of 210. So that's the problem. Aspirin does prevent heart disease. The benefit is small, for sure, but the real problem is that it's outweighed by the risk of bleeding, so you're not really coming out ahead. But the real tragedy here is the public is locked into this idea of everyone over 50 should be taking an aspirin. Even today, even though guidelines have recommended against aspirin for primary prevention for some time. Data from the National Health Interview Survey sample found that nearly 1 in 3 older adults takes aspirin for primary prevention when they shouldn't be. That's a lot of people. That's millions of Americans and Canadians, but nobody cares about us. It's fine. So that's the point. We're not debunking aspirin. It does work. The benefits are just really small in a primary prevention population and offset by the admittedly also really small risks of bleeding. It's a trade-off that doesn't really work in your favor. But that's aspirin for cardiovascular disease. When it comes to cancer or DVT prophylaxis, that's another really interesting story. But we might have to save that for another time. Do I know how to tease a sequel or what? For Medscape, I'm Christopher Labos.